This presentation is on high flow nasal cannula in adults, children, and in neonates. It's often used in the management of acute respiratory failure. As you all know, acute respiratory failure is a life-threatening condition characterized by inability of the respiratory system to maintain adequate oxygenation and or carbon dioxide elimination. It can develop rapidly over minutes to hours and requires immediate medical attention. Early recognition, prompt treatment, and preventive measures are essential to reduce the burden of acute respiratory failure and improve the outcome. It is a significant contributor to global morbidity and mortality, particularly in low and middle income countries where resources are limited. Approximately 20 to 30% of COPD exacerbations result in acute respiratory failure requiring hospitalization. Pneumonia is the most common cause of acute respiratory failure in all age groups. In children, bronchiolitis and pneumonitis cause acute respiratory failure and require hospitalization. This is the data from UNICEF. As you can see, in the under 5 mortality per year is almost 5 million. The most common cause next to prematurity is pneumonia or respiratory diseases. Throughout the world, about 2 million children die from acute respiratory infections. 70% of them happens in Africa and Southeast Asia. The sub-Saharan Africa accounted for 57% of global under 5 deaths, while only it accounts for 30% of the global live births. Southern Asia accounted for about 26% of global under 5 deaths and 27% of global live births. This is the data from United States. As you can see, the usage of high flow nasal cannula has gone up for the past 10 years consistently. Even though invasive mechanical ventilations remain static in the last 10 years, it has not gone up. The question is, why do you need high flow nasal cannula? Number one, it is a non-invasive ventilation, so you do not need to have sedatives, neuromuscular blockade, decreased mobility, potential for airway injury, and potential for oral aversion. High flow nasal cannula isn't just standard nasal cannula turned up to high flow rates. High flow nasal cannula, where the gas is heated up to 37 centigrade with 100% relative humidity. It can deliver 0.21 to 100% FiO2 at flow rates up to 60 liters per minute. The flow rate and FiO2 can be independently titrated based on the patient's flow and oxygen FiO2 record. Well, how does high flow nasal cannula works? Number one, it is heated and humidified. Thus, it improves secretion clearance, decrease airway inflammation, and also decrease energy expenditure. Second, it matches inspiratory demands. The peak inspiratory flow at rest is 30 to 60 liters per minute. It can reach up to 120 liters per minute in acute respiratory failure. High flow nasal cannula attempts to match up with the patient requirement. Third, it improves functional residual capacity. For every 10 liter per minute flow, it increases a PEEP. This is an adult data, especially when the patient is close mouth breathing. It causes alveolar recruitment, increased FRC, and likely because of added PEEP. And most importantly, it is very lighter. There is no mask on the face of the patient. I'd like to explain few concepts. One, the concept of oxygen dilution. When you give regular nasal cannula at 1 liter, it gives 25% of FiO2, 4 plus room air, which is 21, which is 25%. When you increase the flow to 2 liters, it provides 29% FiO2, 3 liters 33 and 4 liters 37. There is 4% increase for each liter increase in the flow. This is called 4-to-1 rule. So how does that work in high flow nasal cannula? If there is a nasal cannula at 6 liter delivering 45%, but your patient is breathing 20 liters per minute at room air, then what percentage of FiO2 do you think is actually reaching the patient's trachea? I don't actually know, but definitely not 45%. And most likely it's closer to 21%. This phenomenon is known as oxygen dilution. On the other hand, in high flow, when you deliver 60 liters, 45%, and the patient is breathing 20 liters at 21%, what is the likelihood of FiO2 in the patient's trachea? Most likely closer to 45% rather than 21%. So thus, high flow minimizes oxygen. Is 5 different ways high flow nasal cannula helps the patient. Number 1, it meets inspiratory demands. Number 2, it decreases oxygen dilution. Third, it is lighter so that you can get more compliance, especially in small children. It increases the functional residual capacity. And the other one is called dead space washout. What does that mean? When you breathe in 21% FiO2. When you breathe out carbon dioxide. When you breathe back the third time, not only you breathe in FiO2 of 21%, you also breathe back the expired carbon dioxide. The high flow nasal cannula washes out the dead space so that you will get more flow and more FiO2 and no CO2. That is called dead space washout. When should high flow nasal cannula be used? In patients with acute hypoxemic respiratory failure in all age groups. And also, one can use to prevent hypoxemic respiratory failure in situations like post-extubation and before intubation. In moderate to severe bronchiolitis in children, in neonatal ventilation, and any respiratory distress of moderate to severe category. This article was published in New England Journal of Medicine 2015, where the high flow nasal cannula was compared with regular nasal cannula and BiPAP in acute hypoxemic respiratory failure. They compare the 3 modalities: high flow, standard oxygen, which is regular nasal cannula oxygen, and non-invasive ventilations against the incidence of intubations in those patients. As you can see, there is a less number of intubation in patients who received high flow nasal cannula than those who received BiPAP, but it is not significant. But when you look at those patients where the PF ratio is less than 200, meaning in hypoxemic respiratory failure patients, the incidence of intubation is much lower than BiPAP and the regular nasal cannula. The p-value is significant. So in hypoxemic respiratory failure, high flow performs much better than other non-invasive ventilation. And also, the cumulative probability of survival is much better with high flow oxygen than regular and BiPAP. That is statistically significant. Should high flow nasal cannula be used post extubation? The answer is yes. This study compared nasal high flow oxygen versus venturi oxygen therapy after extubation. As you can see, the high flow nasal cannula performed much better in maintaining oxygenation, and it is more comfortable, fewer displacement because there is no face mask is used, the oxygen desaturations are less, Those who require reintubation in high flow nasal cannula is less than the face mask oxygenation. All of them are statistically significant. So what is a practical approach to the clinical use of high flow nasal cannula? There are two parameters you need to determine. One, the flow. The flow typically we give 2 liters per kilogram in children. In adults, somewhere between 50 to 60 liters. FiO2 to keep the saturation above 92%. This is an algorithm published in Lancet 2022. This is about pediatrics. Child admitted to the hospital, do the supportive care, and commence low flow oxygen when there is hypoxemia. If the patient has not responded, and commence high flow nasal cannula at 2 liters per kilogram per minute and titrate FiO2. If the patient responds, titrate FiO2 to room air. Once stable in room air, stop high flow, do not titrate flow. If the patient does not respond, escalate the care. I typically do RAM cannula, but this article suggests start CPAP. There is another group. They do a little differently. Initiation is similar to what we discussed, but the weaning, what they did was they wean flow and the FiO2 simultaneously. Wean the FiO2 slowly down to 40 or 50%. Decrease the flow slowly, then switch over to regular nasal cannula. This algorithm is from Yale for adult high flow nasal cannula. What they do, they start with 30 liter with 100% FiO2. Their aim is to keep the saturation more than 92. Then they escalate the flow of 5 to 10 liters to the max of 50 liters. If the patient does not respond, then escalate the care. If the patient responds well, then decrease the FiO2 to keep the saturation more than 92. When the saturation reaches 50%, then they decrease the flow 5 to 10 liters per minute to 10 liters. When the patient reaches 10 liters, 50% FiO2, then they switch to regular nasal cannula. The question remains, what is the right way to wean the high flow nasal cannula? Whether to reduce the flow and the FiO2, or reduce the flow first, FiO2 later, or FiO2 first and flow later. There is a study, ongoing study. We do not have the results yet. Once we have the results, we will know what is better, or all of them are better. We do not know yet. This slide shows the components of high flow nasal cannula. Is the oxygen blender, flow meter, and the heater. In addition, one should have oxygen analyzer and, of course, standard nasal cannula. We are going to see the demo of high flow nasal cannula.
Hey guys, my name is Nakaya. I'm a respiratory therapist here, and today we're going to be talking a little bit about the high flow. So the high flow is a pretty simple, user-friendly, really useful device for pediatric patients. Some of the components that we have here are the flow meter, the oxygen blender, and the heater. So essentially what this flow does is it kind of helps produce a little bit of a pressure. Sometimes if oxygenation is not necessarily the issue, we can have the oxygenation down on the blender and use this flow to help open up some of the airways before we consider things like non-invasive ventilation. Here you can see that this goes from 21 all the way to 100% FiO2. So that's how we control our oxygen, and right here is our oxygen analyzer that reads what we're giving to the patient. So right now we're at 47.1.2, and that's reading from here directly from the flow that's connected to the heater here. The heater is its own separate thing. This is just so that we don't dry out the patient, giving them so much flow. Some connectors that we have here that are pretty useful are this aerogen allows us to deliver nebulized medications to the patient. Otherwise, this heater can do invasive or non-invasive modes, which can be useful if patients are experiencing extreme dry out with this flow. Normally in pediatric patients, we like to do 2 mils per kilo. So we'll have a flow meter that can go usually up to 15 to 30, depending on the size of the patient. And then we also like to have water that connects to this heated circuit so that we are delivering constant heat for our heater and to produce some humidity. And that's the high flow for you.